everyone, I'm Dr. Joyce Habib, and I'm the speaker for today's webinar. Please note down your questions and queries and ask me in the Q&A session. Let's start with today's topic, tumor-agnostic approvals. Where are we now and where are we heading? So what we're going to talk about today are tumor-agnostic approvals. There are 6 tumor-agnostic approvals to date, and I think the list is going to continue to expand over time. We'll briefly touch base on TMB because we have issues with this as a predictive biomarker, so we haven't really done a good job there. And lastly, finish off with the regulatory and statistical considerations for tumor-agnostic indications. So the first approval, tumor-agnostic immunotherapy approval, was from pembrolizumab, and it was in May 2017 in MSI and mismatch repair deficient tumors that had progressed despite standard of care and have no satisfactory treatment option. And so the thought process that for MSI or mismatch repair deficient tumors, these tend to harbor a high mutational load, so they would have high level of neoantigens direct against tumor-specific cells. Tumor cells specifically. And so we would, by using an anti-PD-1 inhibitor, we would be unleashing this activity of cytotoxic T cells against these tumors. And the pool data from 5 single-arm trials was used to land this approval. And we've seen an overall response rate in the pooled analysis of 40%. These responses tended to be durable. So in the updated efficacy analysis of Keynote 158 in the non-colorectal cancer cohort, we've seen that 70% of initial responders kept their response at 3 years. And this is despite stopping pembrolizumab, because in this trial, they capped it at 2 years. And for dostarlimab, the approval came in August 2021, a few months after securing approval for endometrial cancer, again in mismatch repair deficient tumors. And this was based on the Garnet multi-cohort studies. This was a cohort that included the pooled data was from cohort from endometrial and non-endometrial cancer. By and large, these were 93% with GI tumors. And the response rate was 42% in that trial, with 9% CR rate. Duration of response was 35 months. And again, in the updated efficacy analysis from ESMO, I think 2022, we've seen that the responses were durable. And if you had 85% probability of maintaining a response at 24 months. Initially, when these were approved, there was no companion test. However, in the past year, we've seen 2 companion tests. The Foundation 1 CDX assay was approved as a companion test for Pembro to detect MSI high tumors, and the Ventana mismatch repair HC assay was approved as a companion test for both dostarlimab and pembrolizumab. And so if we use those for advanced disease, why not try those for earlier non-metastatic disease? And the thought process is that the more advanced the disease, the lower the prevalence of mismatch repair deficiency or MSI high tumors. And at least this is stage specific for a few cancers, among them colorectal cancer, gastric and endometrial cancer. So for instance, colorectal cancer, 15% of stage 1 and 2 tumors are mismatch repair deficient or MSI high versus only 3 to 5% for stage 4 tumors. And if it works in metastatic disease, there should be more even compelling data that would work in the earlier stage setting, because primary tumors are even more immunogenic than metastatic tumors. And this hypothesis was tested in 2 studies that were presented this past year. One was as ASCO and then published in a New England Journal of Medicine. This was the Memorial Sloan Kettering study, looked at dostarlimab for 6 months in rectal cancer that had MSI high or mismatch repair deficiency for stage 2 and 3 disease. And they saw in 12 patients complete clinical responses across the board. None of them needed chemoradiation or surgery. And the responses, none of them had relapse, albeit with a short duration of follow-up is about a year. In the neoadjuvant setting for colon cancer, we've seen the use of nivo-ipi, 2 doses of nivo, 1 dose of ipi followed by surgery, leading to a pass-CR rate of 67%, and even higher for a patient with germline etiology. Lynch syndrome was pass-CR was 78%. So again, none of them had relapsed at the time of publication, but the duration of follow-up was also about a year. So we don't really know what will happen with long-term follow-up, whether some patients will relapse. We're not really sure how pass-CR in colon cancer pans out as an endpoint, since it's not been validated as an endpoint in that cancer. pCR is maybe a valid endpoint, predictive of prognostic endpoint in rectal cancer. So if a patient will have chemoradiation pCR, we may be able to spare them surgery. We don't really know what the value of pCR is in, for example, rectal cancer if they are treated with just immunotherapy, not chemoradiation therapy. Do I see this as becoming a tumor-agnostic approach? Probably not. We have this data that was published a few months ago, primarily colorectal cancer, but also a few non-colorectal cancer patients that were given pembrolizumab for about 6 months, and some of them were taken and resected, about 17 out of the 35 patients. Compelling data seemed very promising. Response rate was super high. pCR was 65%, but you can't really make anything of that data, seeing that the colorectal cancers patients were very few among these patients. So I don't really think this is going to be expanded to become a tumor agnostic. It's probably this approach is going to be developed in the specific tumor. The prevalence of MSI or mismatch repair deficiency is high, like colorectal cancer, gastric cancer. We've seen data from gastric cancer as well, and potentially endometrial cancer. I don't think it's going to be tumor agnostic. It remains to be determined what's the best approach. Should we use just PD-1 inhibitors or PD-L1 inhibitors, or should we combine those with CTLA-4 inhibitors? How long should we treat? If we were to choose surgery, use that in a pre-op setting, do we need to use adjuvant immunotherapy as well? Are we going to use that in a surgery sparing approach, particularly for rectal cancer, where depending on location, tumor surgery might be quite morbid? And obviously, when we use these in a preoperative setting, if we use pCR, this is not a validated surrogate endpoint for outcome for relapse-free survival and overall survival across all tumors, right? Certainly, I just pointed out that the colorectal cancer, but also, if we use that for endometrial gastric cancer, certainly this marker needs to be validated first and correlate with survival before we move forward with that. And what about biomarkers of response? In the study that I just showed you, they looked at ctDNA kinetics. They looked at the decrease in ctDNA as a potential biomarker of response. That response was defined in pCR. So it would be interesting to explore biomarkers because not all patients will continue to have response. In that study that I just showed you in solid tumors, some of the patients relapsed or progressed and required salvage therapy. So interesting, but not quite ready. So the second tumor-agnostic immunotherapy approval was for pembrolizumab in tumor mutational burden high tumors. And when same thought process for TMB high tumors, that these have high mutational load, more neoantigen, more cytotoxic T cells that you would unleash with immunotherapy. And the way this was looked at in the Keynote 158. This was prospectively planned retrospective analysis of patients enrolled in that study, where they used the cutoff of 10 using to test for TMB using Foundation 1, which was an NGS panel. And the reason why 10 mutational per megabase was used as a cutoff is quite arbitrarily, because it correlated the best with the optimal TMB cutoff that was determined by whole exome sequencing. That cutoff determined by whole exome sequencing had the strongest data as being predictive immunotherapy efficacy in non-small cell lung cancer, but also in other solid tumors. So quite arbitrarily selected endpoint with more than tumor mutational burden, patients with having that biomarker, selected for that biomarker, having a response rate of 29% versus 6% patient with non-TMB high tumors. And these responses seem to be durable. So this landed the approval of pembrolizumab in June of 2020. And Foundation 1 assay, the one that was used in that study, was the companion test. And even though this is the only FDA-approved TMB assay, the MSK impact has also been authorized by the FDA through the 510K pathway. So this is second NGS assay that we can use as well to measure a TMB, a select patient. But if we look at Keynote 158, histology by histology, across the board, yes, you do see higher response rate in TMB high tumors. But for example, if you look at anal cancer, the response rate is substantially lower in TMB high patients compared to TMB low patients. So this variable by histology. And if you look at survival analysis, the PFS comparable TMB high versus TMB low, 2.1 month PFS. And the OS is numerically worse for TMB high tumors, 11.7 versus 12.8 month. And if you see this kind of crossover effect where the blue line dips a little bit and then kind of becomes on top of the red line, meaning that there are patients that are going to progress really quickly in the TMB high population. And very few patients who are at that tail end of the curve are going to have some benefit. So in overall, in net effect, the outcome is numerically even worse. So with the lackluster survival data and this variation in histology, leads us to question whether TMB is truly tumor-agnostic, independent predictive biomarker for immunotherapy. And this variation in response rate was also reported by another group, the Yarshoan and colleagues, showing that, for example, I've shown you data in Keynote 158 for anal cancer, but also for mismatch repair proficient colorectal cancer, you tend to see lower response than you would expect for the TMB. And conversely, for some tumors such as Merkel cell and renal cell, you tend to see much higher response, objective response to immunotherapy than you would expect for the mutational load of these tumors. And to that point of that being questioning whether TMB is an independent predictive biomarker, Russo and colleague looked at various tumors, colorectal cancer on top, and at the bottom, various solid tumors, and they tried to look at these tumors and remove the contribution of mismatch repair deficient tumors. So for example, colon cancer, MSI high tumors all have extremely high TMB and respond to immunotherapy. If you exclude MSI high tumors, so mismatch repair deficient protein, not having mismatch repair deficiency of one of those proteins, or not having a polymerase epsilon or polymerase delta 1 mutation, and you remove those from the equation and just leave mismatch repair proficient tumor, you see that whether you have high or low TMB, you have the same outcome with immunotherapy. So really, it doesn't appear that it has predictive value in that subset of patient. But if you also look at extending this analysis to patients with various other solid tumors, mismatch repair proficient tumors, stratified by TMB, more than 10 mutation per megabase, less than 10 mutation per megabase in that study determined by Foundation 1 assay, you see that for some tumors, such as non-small cell melanoma and head and neck, there is an association with survival. Whereas with a lot of other tumors, gastric, urinary tract, or carcinoma known primary, there's no association with survival. So again, it's not really an independent predictive biomarker, at least not in tumor agnostic fashion. The other study, for example, the same results were seen by Samstein and colleague. They was looking at various solid tumors treated with anti-PD-1 inhibitor or anti-PD-1 and CTLA-4 inhibitor, and they see overall this correlation between overall survival and TMB, high TMB, better outcome. But when you look at specific histologies and you look at the cutoff of TMB that is associated with survival in patients treated with immunotherapy, this is substantially higher. For example, colorectal cancer, it's 52.2 versus 13.8 non-small cell lung cancer. So very close to the cutoff that we use of 10, but very much higher for colorectal cancer. And for some tumors like glioma, having high mutational load is actually associated with worse outcome with immunotherapy. So this variation and cutoff across histologies, variation in response histology, makes you wonder whether there's something specific, the immune microenvironment of each histology does play a role. And to that point, McRail and colleague performed this analysis in tumors in TCGA. There were thousands of tumors they looked at, and they were able to find that for some tumors labeled as category 1 tumor, there was correlation between CD8 positive T cell infiltration and neoantigen load. And these tumors like melanoma, uterine, kidney cancer, and adenocarcinoma of the lung, this correlation existed. And for category 2 tumors, that correlation did not exist. So there was no association with high neoantigen load and CD8 positive T cell infiltration, which included, among others, liver, esophageal, gastric cancer, prostate, and breast cancer, and squamous cell carcinoma of the lung. So the same kind of cancer, lung cancer, adeno, category 1, squamous, category 2. And for category 1 tumors, when you treat those patients with immunotherapy, you tend to see a correlation with response rate, but also survival at the bottom. Category 2 tumors, you don't see any correlation with response rate, and for some histologies, you actually see worse outcome with immunotherapy in TMB high tumors. But then if we focus on one kind of cancer, non-small cell lung cancer, where I've shown you that, the cutoff of 13.8 is very close to the cutoff that we use, that it is associated with overall survival, even if we remove the mismatch repair deficiency from the equation. And at least for adenocarcinoma, there's correlation between CD8 positive T cell infiltration, neoantigen load. How did that fare? How did data fare in that specific cancer? Well, not very good. Whether we look at TMB and whole exome sequencing or NGS, we really did not show any predictive value for TMB in non-small cell lung cancer. There was no association with overall survival. So is it an issue of dividing those into squamous now, non-squamous? Because, the non-squamous, the adenocarcinoma, there does seems to be correlation between neoantigen load and CD8 positive T cell infiltration, and just leave off the squamous. We don't really know. Is it the time that the cutoff that we got wrong? I mean, 10 is 10 mutation per megabase, the actual required cutoff to be able to demonstrate efficacy. It's unclear because, that selection was kind of arbitrarily done from the get-go. For example, in this study by Rishuti and colleague that was done published about a few months ago, they were able to show that tumor burden cutoff, looking at the optimal cutoff, the cutoff of 19 mutation per megabase was the one that had the strongest association with response to immunotherapy among non-small cell lung cancer. So the efficacy, we're talking about response rate, PFS, and OS. And beyond the cutoff, there are various issues with selection of TMB as a biomarker. One, the platform used. We use whole exome sequencing as the gold standard, but for clinical purposes, we use targeted NGS panels. And these panels vary. There's variation from platform to platform used. The panel size has to be at least 1 to 1.5 megabase to be able to call out TMB. The gene content matters because these targeted NGS panels are biased towards somatic mutations. The genes that are that have higher rates of somatic mutations. So we have to take that into account, not to overestimate TMB. The type of alterations measured varies from assay to assay. So non-synonymous mutation are the sine qua non alteration that are associated with TMB, but then other assays, for example, Foundation 1 also measures synonymous mutation and indels, whereas MSK Impact does not. The need for a matched normal sample to be able to exclude the germline variants. And if you don't do that, you have to use a bioinformatic algorithm to be able to do that. So, for example, the match normal is, we do have match normal for MSK Impact, but not Foundation 1. And obviously, the match normal will also simplify your life because you would be able to exclude the contribution of clonal hematopoiesis, particularly if the tumor is infiltrated with blood cell, let's say. Also, there are some issues with purity of tumor sample, artifacts related to frozen formalin fixed paraffin embedded tissue, classically the C2T artifact. What about blood-based TMB? Does that overcome the limitation of tissue-based TMB? No, well, not quite. I mean, we had tons of retrospective analyses that were done, particularly in non-small cell lung cancer, showing association between outcome and immunotherapy with use of blood-based TMB using various assays, various cutoffs, and the most common one used was 16 mutation per megabase, again, arbitrarily because it tended to correlate with the cutoff of 10 mutation per megabase in tissue. So blood-based TMB of 16 correlated with tissue TMB of 10 mutation per megabase, the cutoff. So, but when we prospectively tried to look at this as a biomarker in the BFAST study, in the cohort C of the study, they took patients with non-small cell lung cancer, first line, and they selected them based on at least a blood TMB of at least 10. And they randomized these patients to atezolizumab versus platinum doublet. And when looking at the efficacy, the primary endpoint was PFS in patients with blood tumor mutational burden of at least 16, which is, again, because it correlated with that cutoff of 10 in tissue. We see no difference in PFS and OS. So Is it, again, the same issue with tissue? Is it histology? Because they see an association with non-squamous, but not for squamous cell carcinoma of the lung. Or is it maybe the cutoff? Because when they revise the data and try to look for the optimal cutoff, it seemed that blood tumor mutational burden of more than 20 was the one that had the strongest association with hazard ratio of 0.59 for PFS. So no better than tissue tumor mutation burden. So I think in this area, we haven't really had a success when it comes to that tumor agnostic approval. So moving on, we're going to touch base on the 3 tumor agnostic approval for targeted therapy in oncology. So I covered the 3 in immunology, immunotherapy, and now targeted therapy. And I think everyone is aware of, the NTRK fusions, NTRK inhibitors. NTRK fusions are oncogenic. Their prevalence varies from tumor to tumor. We have very high prevalence for some tumors, such as MASC or secretory breast cancer, and some infantile tumors, infantile fibrosarcoma and mesoplastic nephroma. Intermediate prevalence between 5 to 25% for some tumors, such as GIST, splenoid tumor, or thyroid cancer. And for some pediatric gliomas, that would fall in the intermediate category because they tend to occur much higher in high-grade gliomas in the pediatric population compared to the adult population, and a very low prevalence for the rest of the tumors. So the most solid tumors, as well as hematological malignancy, would be less than 5%. The way that we detect them is use NGS panel primarily. Only for the very high prevalence tumor, we can use IHC to be able to see whether it's positive. If it's positive, we don't need to confirm that with an NGS panel, but with the lower prevalence, the positive predictive value decreases, false positive increases. So for lower prevalence tumors, you can't really use IHC. RNA-based NGS assay are superior to DNA-based NGS assay. They tend to be more sensitive and more specific because of, they can detect all fusion partner. It doesn't matter what the breakpoint is, what intronic sequence it occurs. And it's also able to detect whether that fusion actually causes a functional transcript or not, which DNA NGS is not able to do. It seems like liquid biopsy may be also a valid way to test for those. There was a study this past year showing a high concordance between liquid and tissue detection for these fusions. And so we have 2 TRK inhibitors that are approved. One was approved 2018 and 19, so larotrectinib and entrectinib, and an NTRK fusion positive solid tumors. And the efficacy data leading to approval for both of these drugs was based on pooled analysis from 3 trials for each of these agents, enrolling approximately the same number of patients, 55 for larotrectinib and 54 for entrectinib. And the overall response rate for larotrectinib was 75% with a CR rate of 13% and a response rate of 57% with CR rate of 7% for entrectinib. Again, the PFS was also different between these 2 agents, with a median PFS of 29.4 months for larotrectinib versus 13.8 months for entrectinib. Now, if you think about it, maybe larotrectinib looks like it's more effective than entrectinib. Bear in mind that the larotrectinib and entrectinib trials enroll different patient populations. So for instance, in the entrectinib trial, you had a higher proportion of patients with CNS metastasis. These tend to have worse response and worse outcome. And there was much less patients with pediatric tumors compared to the larotrectinib arm. So the larotrectinib trials having pediatric tumors, these tend to have dramatic responses to the NTRK inhibitor and more improved outcomes. So this may have led to this huge difference in PFS. Also, the choice, how to measure the overall response rate was different. This was blinded independent central review for entrectinib versus investigator assessed response for larotrectinib. So it may have caused a discrepancy in response rate. And the CNS activity, at least for entrectinib, seems to be more compelling. Entrectinib, by speaking, spiritual, it's not a protein substrate, so it tends to go in the CNS and remain in the CNS, not moved out of the CNS. And if we look at the data on CNS metastasis, we have a lot more patients with CNS metastasis in the entrectinib trial compared to only 12 patients with CNS mets, not primary CNS tumor with larotrectinib. And the intracranial response rate was 69%. patients in entrectinib for CNS metastasis patients versus about 25% for patients who have in the larotrectinib trial. There's no head-to-head comparison beyond, the CNS activity, being more compelling for entrectinib, matched adjusted indirect comparison seems to suggest that larotrectinib is better than entrectinib. However, the limitation is that, the trial, how the trial was conducted and the selection of population, it cannot be overcome when you do these kind of analyses. So what about resistance? So, we see great responses, we see impressive PFS data, but invariably resistance is going to happen. So resistance occur commonly through secondary kinase domain mutation, what we know as on-target mutation. These are solve-in-front, gatekeeper residue mutation, or mutations in XDFG activation loop motifs. Resistance can also occur less commonly through activation of bypass downstream signaling involving activation of kinase signaling through various mechanisms. Could be BRAF mutation, KRAS mutation, MET amplification, among others. What is interesting, for example, in the study, in NTRK fusion positive colorectal cancer tends to occur in BRAF wild type and KRAS wild type colorectal cancer as determined at the time of diagnosis. And so, for example, in that study, they determined that acquired resistance colorectal cancer was occurred via KRAS and acquired KRAS mutation. And so, for example, for colorectal cancer, you may have a KRAS mutation that you didn't detect upon the time of diagnosis that happened throughout treatment. And when you treat with the TRK fusion inhibitor, the TRK inhibitor, you probably will get less response because of that existence, that mutation. But it's probably underreported because a lot of the studies that have looked at TRK fusion positive colorectal cancer and looked at the coexisting alteration were done at the time of diagnosis using archival tissue. So the second generation TRK inhibitor, repotrectinib and selpercatinib, were developed to overcome some of the resistance mechanism. They don't overcome the activation bypass signaling, but they do overcome some of the kinase domain mutations. So the on-target resistant, particularly solve-in-front and gatekeeper mutation, but they cannot overcome the mutation in the activation loop motifs. That would require type 2 TRK inhibitor, which would be active even in the DFG out inactive state of the kinase. So when we look at, for example, repotrectinib, which was designed to overcome, some of the on-target resistance, and this was looked at in the Trident-1 phase 2 study and looking at the expansion cohort 6, which enrolled patients who are TRK fusion positive and were previously treated with a TRK inhibitor and had progressed. We tend to see an overall response rate of 48% and even higher response rate in patients with solve-in-front mutation. And these occurred about 57% patient in that expansion cohort. So they tend to be quite prevalent. Obviously, cannot overcome bypass pathway activation and XDFG motif mutations. The second tumor-agnostic approval is for BRAF mutation. It was PRAF combination of dabrafenib and trametinib, which was initially approved for anaplastic thyroid cancer, non-small cell lung cancer, and melanoma. But the tumor-agnostic FDA approval in June 2022 was for all solid tumors except for colorectal cancer, was based on a basket trial, the NCI-MATCH study, the ROAR, BRF-11701, which is ROAR study, and as well as a small population of pediatric patients with low and high-grade gliomas. So in the NCI-MATCH study, which enrolled solid tumors, leukemia, lymphoma, and myeloma, excluding melanoma and thyroid and later lung cancer, we see compelling overall response rate, PFS, and survival data. In the ROAR basket trial, we also see compelling data for biliary tract cancer, with a response rate that is impressive and median overall survival that is also compelling. In the glioma cohort, also impressive activity in the high-grade glioma, and overall response rate 31%, and a median overall survival 17.6 months, including 13.7 months for patients with GBM. And just to give you that perspective, cytotoxic chemotherapy, we're not even able to achieve 10% response rate in high-grade glioma. So that is very compelling data. And in low-grade glioma, the response rate was even higher. What about other histologies? In the MATCH trial, there were 5 patients with low-grade serous ovarian cancer, and there was impressive activity as well as durable activity for these patients. This was also substantiated in other case series, showing that, if you find these mutations, low-grade serous ovarian cancer, you have durable, impressive activity and durable responses. What about non-biliary tract GI cancers, such as GI neuroendocrine tumors, particularly colorectal neuroendocrine tumors, because these are enriched in these types of mutation, or pancreatic cancer? We don't have partial responses reported in the MATCH study, but very limited number of patients. You can't really make much of that. Few case reports. So we're not really sure that the efficacy that we saw for biliary tract cancer extends to these other tumors as well. What about hematological malignancy? We know that BRAF mutation is extremely common in hairy cell leukemia. About close to 90 to 100% of patients have these mutations. And this was looked at in the ROAR study, the cohort of patients with hairy cell leukemia that had relapsed refractory disease. And the response rate was really impressive, and a CR rate was 65%. And more importantly, these responses were durable. The same cannot be said about the combination of encorafenib and binimetinib in relapsed refractory multiple myeloma. The prevalence of these alterations less common in multiple myeloma, but tends to increase when you have relapsed refractory disease and it's associated with poor prognosis. So in that Burma study where they looked at that combination, that setting, in patients harboring this mutation, we've seen a very high response rate. However, the response was not durable, and the resistance occurred quickly, and it was driven by RAS alteration and BRAF alterations. So histology matters. Response rate may be high, but it doesn't mean anything if the response is short when you're talking about tumor agnostic indications. The last tumor agnostic indication came about for RET fusions in solid tumors. RET fusions are extremely rare. They're present in about 5 to 10% papillary thyroid cancer and 2% non-small cell lung cancer, but outside of these, they are extremely rare in other solid tumors. We had previous approval of 2 RET inhibitors for papillary thyroid cancer and non-small cell lung cancer, and then so more recently, we've seen approval for solid tumors outside of these 2 histologies. There are multiple fusion partners, and the best way to test for these is RNA-based NGS testing. It's superior to DNA-based NGS testing, and IHC and FISH are poor. Their sensitivity and specificity varies depending on the fusion partner, so it's really not an accurate way to detect for these fusions. So both pralsetinib and selpercatinib were evaluated in tumor-agnostic fashion in solid tumors. One was in a phase 1/2 ARA study for pralsetinib with a response rate of 57%, with the albeit lower, modest PFS at 7.4 months. Selpercatinib, which led the study that led to its approval for tumor-agnostic purposes, in September 2022, with the use of selpercatinib across various tumors, primarily pancreatic ductal carcinoma and colorectal cancer. These were both histologies with the bulk of the tumors that were enrolled in that study, showing a response rate of 44%, a more impressive PFS, almost a double, 13.2 months. And so these responses tended to be durable. But when you look at histology by histology, we can only look at the 2 main ones, colorectal cancer and pancreatic ductal carcinoma. We see that the response rate for colorectal cancer is about half that you would saw with pancreatic cancer. And again, this kind of opens the question of these RET fusion positive colorectal cancer, just like I've shown you that NTRK inhibitor or NTRK fusion positive colorectal cancer at baseline, if you test the tumor at time of diagnosis, these tend to be RAS wild type, and BRAF wild type tend to be MSI high. But you don't really know what happens with these tumors over time. Are these tumors, these are BRAF and RAS wild type, they're being treated with EGFR targeted therapy, or these acquiring mutations activating MAP kinase signaling, leading to resistance. Therefore, you see lower efficacy with RET fusion inhibitors. And to that point, there was a study that looked at various mechanisms of resistance to selpercatinib in non-small cell lung cancer, thyroid cancer. In that study, they used longitudinal cell-free DNA analysis, but also looked at tissue. And what they saw for thyroid and non-small cell lung cancer is that on-target resistance, these solvent mutations, solvent front or hinge region, do occur. But these are minority of mechanisms of resistance to selpercatinib. Pralsetinib and selpercatinib were designed to overcome gatekeeper mutations. So gatekeeper mutation is not a mechanism of resistance, but other mutations can occur. That's common. These are the on-target resistant. But by and large, the main mechanism of resistance was bypass signaling activation, primarily MAP kinase signaling activation through various alterations that would occur. These tended to be polyclonal. And if you looked at tissue only, you could miss those. So these sometimes co-occurred as well with solvent front mutations for some patients, like in the figure on the last, the G figure, showing that multiple mechanisms were operating at the same time. So if you do tissue only analysis, and if you do tissue at the time of diagnosis, you're going to miss those. And those will tell you if you have an already pre-existing KRAS mutation response and you have RET fusion positive colorectal cancer, your response to selpercatinib maybe lower than if you didn't. Again, within that same process, this was an interesting study where they looked at BRAF and KRAS wild type. 96% had no alteration time of diagnosis. A large majority of those received EGFR targeted therapy, and they had patients that had metastatic colorectal cancer. Forgot to point this out. And when you track them over time, these patients can develop fusions, RET fusions, NTRK fusions, BRAF, FGFR, etc. And those patients, when they develop these fusions, they also tend to harbor subclonal alteration in MAP kinase signaling players, leading to potentially innate resistance if you were to use this RET fusion inhibitor therapy. So at the time where you develop that, you're also developing these subclonal alterations that are primarily adaptive in nature after following treatment with EGFR targeted therapy. And in this last section, we're just going to cover briefly some issues related with tumor-agnostic targeted therapy. So there are three key issues with tumor-agnostic approvals. One, the biologicals. From the biological standpoint, we're making a guess that this, provided that we find a specific alteration, that targeting this alteration would lead to the same efficacy irrespective of the histology. So there's a histology-independent mechanism of action, and that there is no histology-specific mechanism of resistance. So if you use that, the resistance is going to be the same. The mechanisms of resistance are going to be the same, and there's no one mutation that may have primary resistance to this targeted therapy. And this is very an estimation, because we don't really know, because these alterations, when we select for them, there's quite rare. So we sometimes don't have a sufficient number of patients to be able to look as whether there's difference in histology when it comes to resistant mechanism. And I've shown you over and over with colorectal cancer, whether having these alteration and MAP kinase signaling may be associated with lower response with NTRK inhibitors or RET fusion inhibitors in colorectal cancer specifically. There are also statistical consideration how to design these trials. There's a lot of heterogeneity in these trials, how to correct for type 1 error in these studies, how to choose the best biomarker. Response rate is chosen, but having a high response rate does not mean that it's durable. And some regulatory issues, we'll touch base on that in the last slides. So biology matters. For example, the poster child, BRAF mutation, colorectal cancer, BRAF inhibitor with the monotherapy and combination MEK inhibitors did not work. This is because they will have activation of this MAP kinase signaling. So we need EGFR inhibitors to overcome resistance. Same for sotorasib, adagrasib in KRAS mutant colorectal cancer. Data in colorectal cancer was substantially worse than we've seen data in lung cancer. So again, this has been looked at now in combination with EGFR inhibitor therapy. So there's a difference in these signaling occurring colorectal cancer as to occur to other tumors. And similarly, in with fusion-positive colorectal, be it NTRK or RET fusion positive, we may have activation MAP kinase signaling, particularly under the selective pressure of treatment with EGFR inhibitors, which may lead to lower efficacy, the lower response rate that we've seen with RET fusion, and also the lower response rate and lower, PFS compared to other solid tumors that we've seen with larotrectinib and entrectinib. So these are the data from larotrectinib in GI cancer. This was, I think, presented in ESMO 2022. And you see PFS of 5.5 months, which is very comparable to what we would have with cytotoxic chemotherapy in the second and third line setting. Again, as well, I've been showing you with the entrectinib trial, and I think it was also presented ESMO 2022. The difference in response rate was substantial across GI cancer, pancreatic cancer 75%, 20% colorectal cancer, and the PFS was even lower for colorectal cancer, is about 3 months. So the demonstration of histology-independent activity without looking at resistance mechanism limits generalizability. And sometimes you're not able to do these studies because, these alterations are so rare that you're not going to have a sufficient number of patients to test for this. And when you did these tumor-agnostic trials are designed, they're not really designed to look for these mechanisms of resistance, to be able to tease out whether that happens in that histology or not. Often, the trial does not have embedded biomarker analysis, or they're using archival tissue to look at the full mutational spectrum or immune profiling. And then there's lack of we're not testing cell-free DNA because, as I've told you, if you do only tissue NGS, you may miss these subclonal alterations. And if we look at post-approval data that are exploring mechanism of resistance, because of the numbers, we may be limited to data from anchor malignancies, the malignancies which have high prevalence of these alteration, but no data in the tail malignancy, the very few malignancies that are within these tumor-agnostic trials. How do we define clinical efficacy? We know we use overall response rate, but response rate 20% means something in one tumor, and that does not mean the same in another tumor. We don't really know how this alteration affects prognosis. So if we look at, for example, NRG1 fusion, non-small cell lung cancer, they're worse prognostic, they have worse prognostic value. We don't know if it's the same for very rare tumors where we can detect this NRG1 fusions. So we don't really know what to make of that response rate. Are they going to do just the same with cytotoxic chemotherapy or worse? And you need certain numbers of patients to be able to make that determination. Again, if the response is not durable, it doesn't mean anything. We've seen that with sotorasib and KRAS G12C mutated non-small cell lung cancer, great overall response rate. But when it came down to comparing it to standard of care, versus docetaxel second line, the PFS data was just very, very modest. And how to design these tumor-agnostic trials, how many patients should we include in each cohort, how many tumors should we include in these trials, how to correct for type 1 error, because these trials are fraught with type 1 error, and you have to, because of multiple comparisons, multiple treatment arms. And then when we do these conditional tumor-agnostic approval with follow-up studies that are necessary to determine efficacy, we don't really have high-quality data. We just have these expanded cohorts, and we're not really, with the exception of a few anchor malignancy, we're not really able to compare that drug to standard of care. And obviously, the difficulty of designing these trials when you have all these regulatory agencies that vary in their threshold to determine what is, what the evidence that would consider as valid when it comes to tumor agnostic trials. Last slide, regulatory consideration. What happens when the survival data are lackluster, when the biomarker doesn't really pan out? We've seen that with TMB. Are they going to withdraw the approval? What happens if the phase 2 trial evaluating efficacy in an anchor malignancy, not the tail malignancy, does not show benefit after accelerated approval? Are we going to extrapolate this to all other tumors? We're seeing that it didn't show efficacy in the anchor malignancy. Would we need to modify this, for example, approval, say, for example, in gliomas, if you have TMB high and they do worse with immunotherapy, and even in CNS tumor, if they're MSI high, there are data showing that they have worse outcome. Should we make some exceptions based on the data that would come, and what number, what quality of data do we need? Companion tests are not necessary when non-proprietary assay with high level of accuracy are available. But for example, we're shifting the gears from tumor-agnostic fusions or mutation, where detection of this is quite accurate, to more tumor-agnostic therapy directed against any level of HER2 expression. And HER2 expression, for example, is very heterogeneous across tumors. So when we do a HER2 low basket trial, did we validate this HER2 expression among classically tumors where we haven't really treated with HER2 targeted therapy? And how do we model cost-effective analysis for tumor-agnostic therapy? Who pays for that, and based on what modeling analysis? Because historically, we need survival data to tell you whether treatment is cost-effective or not. So there's huge regulatory headache for tumor-agnostic therapies. And with that, I conclude this presentation.